Right. So I'm Monica. I'm the dietitian that cover the MICU, PICU, and the CSI. So I'm going to be talking today about enteral and parenteral nutrition, which most of our patients in the ICU are dependent on nutrition support. Yeah, so the objectives of today's presentation is first that you understand what nutrition support is and why is it so important here in the acute care setting. Also to identify the indications and the contraindications of nutrition support, the importance of the timing and the appropriate route to use, and also to understand how to monitor and manage this type of nutrition. So first of all, we need to know why is it important to start nutrition support. So there's a very high incidence of malnutrition in hospitalized patients. And ASPEN, I don't know if you know what ASPEN is. ASPEN is the American Society of Parenteral and Enteral Nutrition, and that's the society that we base almost all of our recommendations. So they came up with this definition of malnutrition is an acute, subacute, or chronic state of nutrition in which there are different degrees of either overnutrition or undernutrition, with or without inflammation that can lead to changes in the composition and function of the body. It's very prevalent. 30 to 50% of hospitalized patients are malnourished. Even obese patients can be malnourished. If patients are malnourished, they have increased risk of complications. They have poor wound healing. They have a compromised immune system. Their organs are not functioning as good as they should. They have increased rate of mortality and increased healthcare costs. So there's 1 in 3 hospitalized patients will be malnourished upon admission. So this is the reason why it's so important for you, because you're probably the direct providers to understand why we need to give adequate nutrition to the patient. There's been different definitions of malnutrition over the past couple of years, but there was an international consensus that came up with these definitions that are what we usually use here and I think everywhere in the world. So they divided malnutrition either in starvation-related malnutrition, chronic disease-related malnutrition, or acute. So starvation would be someone with anorexia nervosa or someone with alcoholism before that turns into a cirrhosis. But it's just someone who doesn't eat just because they don't want to eat. Or maybe because they don't have access to food. Then we have the chronic disease malnutrition, where there's some degree of inflammation that may be contributing to the malnutrition. And that would be patients with chronic diseases like cancer, obesity, organ failure, different diseases. And then we have acute disease or injury-related malnutrition, which is what we mainly see in the ICU. So it's patients who have major infections, burns, trauma, sepsis, closed heart injury. The thing is that, as you know, most of our patients have chronic diseases plus acute diseases. So that's why inflammation can be really high in these patients. And this is just a continuum, so you can see patients with obesity have already some sort of inflammation. And as all these conditions, all these different diseases, like patients who are on dialysis, who have cancer, HIV, inflammation increases, as you all know, and then sepsis, trauma, that's even higher. So our patients in the ICU have, most of them will have acute malnutrition if they meet the criteria. And just before we pass, so here, since we transitioned to EPIC here in the hospital, we as dietitians can diagnose malnutrition. I don't know if you've ever seen, there's different criteria if they've lost muscle mass, if they've lost weight, if we can see temporal wasting, if they haven't been eating over the past couple of days, couple of months, if, what else, I think, so there's different conditions that we can, or edema and other things. So if we diagnose it, then we'll put it in, and then you'll get we need a code signature, and that's from any of you or the PAs or the attending. The importance of that for the hospital is that a malnutrition is now, it can be coded like IT, what is the, for reimbursement. So that's why if you see a malnutrition note that we put in there, of course, you can see it and then agree or not agree. But it's important if you ever see a malnutrition note that meets that code signature, then you can just find it. Any provider can find it.
For like an ICD-9 thing.
Yes, yeah. So that's for the hospital. Usually some provider will see it and eventually sign it, but if you see it, you can just do it. So then we know malnutrition is important. So as dietitians, the Academy of Nutrition and Dietetics came up with this nutrition care process in order to standardize care and provide like high quality care for the patients. So it's usually divided in assessment, diagnosis, intervention, monitoring, and evaluation. So here in the hospital, so first we have screening, and that leads to a nutrition consult. For screening, most of the screening will happen either in the ER or time of admission, and there are different policies that will pop up a nutrition consult for the nurses or maybe to any of you. This screening can also happen just during length of stay if patients are not eating well, or if they develop a pressure ulcer, or if they get transferred to the ICU and then they're intubated and need tube feeds. So all these are, or us as dietitians every morning, we screen our floors and then we see if someone has to be seen by a dietitian. And these are just different policies here at Monty. So if someone has a pressure ulcer, someone's on tube feeds, hasn't been eating for more than 5 days, has significant weight loss, uncontrolled diabetes, or renal disease, all these reasons you should put in a consult, okay? You and the nurses, they can all put it in, and then we'll see them. We will screen and we'll try to see them, but sometimes we may miss them. But if you see any of these conditions, especially like pressure ulcers, I know that's like a very important one. Usually in the ICUs, I and the other dietitians at the other ICUs will try to see the patients almost like different than the other floors. But still, if you see some of these conditions, you can also see those nutrition.
Why?
Pressure ulcers, because they need, so for pressure ulcer wound healing, they need high protein and high calories to help them. So that's why for patients we're not getting, for eating poorly and they're like older and they're not metabolized, then their pressure ulcers so the assessment is going to be completed by us, the dietitians. We look into like weight history, past medical and surgical history. We do physical assessment. Now we've been training on doing that just to assess like muscle loss or fat loss. We look at diet history, and then we look, of course, at the clinical condition, and that's where we discuss with you what the plan is and what the family wants. And then we do all this, and then we decide if the patient needs nutrition support, which would be from enteral or from parenteral nutrition. And then this is just two questions and see if you know a little bit about nutrition support. So question number one, if you're using the normal route of digestion as a portion of the GI, we will support the maintenance of the functional integrity of the gut, the gut barrier function, the gut-associated and mucosal-associated lymphoid tissues, or all of the above. What do you think? Yeah, good. That's why it's so important to use the gut if we can use it, because if not, then there's high risk of infection and other complications. And then this is another question for patients who are in the ICUs. Enteral nutrition should be initiated early, within how many hours of admission to the ICU? Yeah, so a lot of research has been done, and they've shown there's a really good window of opportunity if patients are fed within 48 hours of admission once they're fluid resuscitated and stable. They can be stable on pressors, so we can still feed them if they're on pressors, but usually we should feed them within 48 hours of admission. So this is an algorithm that helps us and can help you decide if patient needs nutrition support from enteral or from parenteral route. So if there is no contraindication for enteral nutrition, we should always use the gut, because then TPN can have higher risk of complications. So if we don't have contraindications, then we should decide if the patient is going to need a short-term enteral nutrition or long-term. If it's short-term, we usually do the NG2. That's the most common one. We can also do post-pyloric NJ or, usually NJ2. And that's also usually recommended for patients who have a high risk of aspiration. I know that sometimes it's hard because I don't know, is the NJ2 placed at that side, same as the NG? Or no? like an NG, a subpylori. It's hard. That's why it's usually most commonly used as the NG2, but for someone who may not be tolerating feeds for a long time or has a high rate of aspiration, we can do that. And then if the GI function is normal, then we can just use a standard formula. I'll go over the types of formula later. And then if the patient is activated or if the patient is tolerating, then we should try oral feed. Our goal is always going to be to transition them to eat orally. If the patient has a GI function is compromised, then we have some specialized formulas that we can use. But as soon as that resolves, then again, we should go back to standard formula and then hopefully lead them to oral. If there's contraindications for enteral nutrition would be an intestinal obstruction, ileus, peritonitis, bowel ischemia, or intractable vomiting and diarrhea, then we should consider parenteral nutrition. So of course, our enteral nutrition would be our first choice, but parenteral nutrition is not bad, okay? So if we need to give nutrition, we can use parenteral nutrition. And here's the same thing. We'll see if patient needs short-term parenteral nutrition or long-term, and if they have a central axis. So a lot of the patients here may have a central axis, so we don't need to do PPN. It's better to do the TPN if they have a central axis already. If they don't and they expect the patient to be on parenteral nutrition for 10 days, then we can do PPN. But if the patient already has a central line, then we can do a TPN because that way we can give them 100% of their needs. And again, once the GI function resolves or all those issues resolve, then we should transition either to enteral feeds or oral. So as you know, enteral nutrition is just providing food directly to the GI tract, and that's the gold standard, and it's the most physiological form of nutrition. And as we talked before, it just helps with the integrity of the gut, also with gallbladder function, immune function, and there's been a lot of RCTs showing that if we use the enteral route, then there's reduced infection complications from pneumonia, sepsis, IV line infections, and even like intraabdominal abscess. Like I said, usually these are the two that we use most commonly here and like in general in other hospitals, which would be the NG2s and the PEG. If patients have an oral cancer, they go to surgery, they can put a G-tube there directly. They shouldn't wait because it's very likely the patient's going to require like long-term nutrition. But usually these two are the ones that we use. We talked a little bit more about this. It's also important to consider what the patient wants and what the family wants. So that's why usually I'll ask you, or the dietitian will ask what the plan is. And just other contraindications, someone with like small bowel syndrome may not be able to get enteral nutrition, should get CPN. There's, depending on how much it was resected, then there's like a 1 or 2 year frame where they can work towards giving some enteral nutrition to help rebuild like the intestine so they can use it again. But all this are fistulas. Even if a patient have a high output fistula, it depends on where it is. If we can bypass the fistula, we should still use the enteral route. There's some complications, nausea, vomiting. We can use some prokinetics if it's medically indicated for the patient. Could be some abdominal distension, maldigestion, malabsorption, diarrhea. And just for diarrhea, I want to mention diarrhea is not always caused by the feeding. Sometimes a lot of these patients are a lot of antibiotics and a lot of other medications. So it's just coming, like looking into everything and deciding. We have, if you go to that. Oh no. Well, we have some modulars like soluble fiber that we can add and help like both the stools or other medications that we may need to add to help with that. Also to consider some infection sources, so like C. diff. So diarrhea is more, there are a lot of factors that could affect it. Timing, we talked about for the ICU, usually we want to start within 48 hours. But for patients who are nourished, if they're expected to eat, if they're not expected to eat for more than 7 days, then we can start nutrition. If we're expected to see a patient whose mental status is not a goal, but patient like probably within the next 2 or 3 days is going to be better, then we can wait. We don't want to put an NG2 right there. For someone who's malnourished, we don't want to wait as much, so we are a little bit more aggressive for patients with malnutrition. So for dosing of enteral nutrition, the gold standard is an indirect calorimetry, which is a machine that we don't have here. It's very expensive. Not a lot of hospitals have them. The CHAM dietitian that covers the PICU and I, we've been talking, so we're hoping we will eventually try to get it. But if not, Aspen has said that we can use just like predictive equations, which is, I know you've seen like 25 to 30. Those have shown with research that it feels very similar to that. So the range is usually between 20 and 35. For obese patients who are critically ill, we want to give them hypocaloric feeds and high protein. That's why the 25 to 30 won't apply to the obese patients. As you know, a lot of patients here are obese or even like morbidly obese, so there's different ranges that we use to calculate this. Like just so you know, like Aspen recommends 11 to 14 calories of current body weight for obese patients. For protein, we do want to give them a lot of protein. Protein turnover in the ICU is really, really high. So for general population, just so you know, it's usually 0.8 to 1 grams per kilo, which can be low for some patients. But in the ICU, we want to give them, if their BMI is less than 30, 1.2 to 1.5. And if it's more than 30, we can go up to 2.5, okay? Again, there's been a lot of research done, especially lately over the last few years, saying how protein is really, really important in the ICU, even for renal patients who are not on dialysis. Because that sometimes is a conversation with most renal doctors are not concerned about this, but some that maybe learned it a different way before would want to restrict protein, but it should be restricted in the ICU. Outside the ICU, things are completely different, but in the ICU, we should restrict protein. Fluids usually between 30 and 40 mLs per kilo, but here we need to consider if patients have CHF or if the patient's getting a lot of IV fluids, then sometimes we don't give them any fluids for the NG tube. And then we monitor sodium, and depending on sodium, then we'll assess if we need to do it or not. And then for macronutrients, a lot of the times they'll meet their needs with the formula, but that just depends on the volume. So that's why sometimes we recommend adding a multivitamin or Necrovite. The reason why we add that is because when the patient's getting total volume meat, doesn't need the micronutrients. So if we recommend the multivitamin, not just because we want to recommend it, it's just because it's not providing enough to meet the RDA or CRI. There's different ways.
Right.
Sure.
Why do you guys recommend hypocaloric for the specifically ill patients?
For obese. So it's just for obese.
Oh, obese and critically ill.
Yes. Yeah. So no.
Okay.
Obese. Yeah. So for patients who are not obese, we would recommend just cancer and normal. We would start at the lower end because we don't want to like overfeed them. And then if they're tolerating, if they're still hemodynamically stable, then actually after, then their needs are really high. But just initially, you want to be a little bit more conservative in calories. But once they're septic with that resolved, then they actually may have even like 35 to 40 calories per kilo. And there are different ways we can deliver enteral feeds. Bolus feeds is when you see, and then we recommend like 250 5 times a day. We usually don't do that in the ICU. ICU, the standard of care is to do continuous feeds. One, it's usually better tolerated. Usually also it helps with blood glucose control because we're providing it over 24 hours. But for some patients, I've had patients who've been here for a long time and they've had issues with tolerance, or you need to, they go to tests and then they're just not getting enough nutrition, then we can try some bolus feeds. The thing with bolus feeds is that a lot of the ICU patients have a delayed gastric emptying, so if you're giving them a bolus feed, sometimes they may not tolerate it as well as someone outside of the regular floor. Then we have intermittent feeds, where we feed them for a couple of hours and give them some time to rest, and then we start again. A lot of oral cancer patients may start with continuous feeds and then try to transition to intermittent feeds and then to bolus feeds. So it's really very individualized, but here in the ICU and in general in the hospital, we'll do continuous feeds because that's what has shown to improve tolerance. And trickle feeds and trophic feeds, we also use them here mainly. Usually they don't use them on the regular floors. This would be for patients who maybe had important like GI surgery, or patients who are not very stable we want to start to build some nutrition, but don't want to be very aggressive. Or someone who's at risk of refeeding syndrome, which I'll talk a little bit more. We don't want to feed them very aggressively because that could lead to some electrolyte depletion and heart abnormalities. So we have different formulas. We carry a formulary, which I was going to bring, but I'll share with you after. There's different formulas that we have here in the hospital and everywhere else. And there's standard formulas or polymeric formulas. Those formulas contain fiber, and they're usually just 1 calorie per ml. Then we have energy dense, which would be 1.5 calories per ml or 2 calories per ml. Just so you're familiar with some of the formulas. So standard polymeric would be Nutrin 1.0, which we rarely use here because it's just sometimes provides a lot of volume. Like glytrol, energy that would be the isosource 1.5, Nutrin 2.0, peptide-based elemental would be vital, would be Peptamen 1.5 or 1.0. Peptide-based are the ones that protein is broken down completely, and the type of fat is also lower, and it's just easily digested. So that's why for patients who are very, very, very sick, we don't want to give an extra load to the body, so we'll use sometimes the elemental formula. Or if they've been having diarrhea, we've tried everything, and it's just not improving, then we may switch it to that and see if that helps. Then there's some specialized formulas, which are renal formulas, hepatic diabetic union hasting. But here, research has also shown that we don't, like, these formulas are no longer used. Hepatic formulas, COPD formulas, those are no longer used because research has shown that there's no difference in using those formulas. Renal formulas, however, we can use them especially if their electrolytes are high, especially potassium. The thing, if a patient's on dialysis but electrolytes are fine, we don't need to use a renal formula. We can use a concentrated formula, but you don't need to use a renal formula. And then we have blenderized formulas we don't use in the hospital for usually mainly used for kids with long-term, and parents try to do that mainly usually at home. And then just one thing, deciding which formula should always be individualized. So there are a lot of formulas that would fit for different patients, but we should always decide which one is the best for each individual patient. So when you're choosing, so let's say you have a patient, but we are not here at night, or you just want to start some nutrition before we can actually assess the patient. So first of all, you'll see what the current condition of the patient is. Then look at the past medical history, surgical history, maybe the patient had some like GI surgery. Look at the last, like I said, electrolytes, especially potassium, would indicate if we need to use a potassium-restricted formula, and then you would consult us usually most of the time. So then we'll go and then we'll assess and see which formula we can use. Another thing with the types of formulas, fiber is kind of a controversial topic in nutrition support in the ICU. It's not hemodynamic with glycemia. So for patients, usually, I don't know if you know Dr. Martindale, he wrote a section of the guidelines. What they recommend is there's only probably like 5 or 10% of ICU patients that shouldn't get any fiber at all. The rest are probably okay, and usually once they're stable, we should give them fiber because we need to keep the gut functioning. But for those patients who are on multiple pressors or just not stable, like MAPS up and down or just low, then we should avoid fiber. And then if we want to avoid fiber, usually the formulas here we can use our Replete, Vital, Peptamen 1.5. Those are the ones that have no fiber. And then as soon as they're more stable, then we can transition them back to a standard formula. We have different modulars using better protein. So that just gives extra protein. There's the pack and has 6 grams of protein and 25 grams of calories. So sometimes the patients are meeting calories but not protein because now research saying they need a lot of protein. So that's why we sometimes add the protein. We have fiber, we have fat, even more calories and amino acids. But here what we use mostly is just protein and fiber. And that's also it's part of the 2-feed order, and you can add it in there. All right, so then we'll transition to what's parental nutrition. So it's another 3 questions. What is the optimal nutrition support for a moderately malnourished patient who has amelia, but it's expected to be resolved within 7 and 8 days? PPN, NG2, phosphoryluric, enterophase, or PPN? PPN, yes. The key word here is moderately malnourished and 7 to 8 days. So if this patient was severely malnourished, then this patient would need TPN. But since it's moderately malnourished, there's not an indication for TPN. And we don't want to use the gut if they have amelia. And then TPN is contraindicated in which of the following conditions? If the patient's DNR, they have peritonitis, an intestinal hemorrhage, or high astrocytosis. Is it tricky? No, not tricky, but could be. No, so it's DNR actually. So yeah, so that's why goals of care are very important, especially for patients where maybe palliative care is involved. Sometimes the family may still decide they want to feed the patient, so we do it, but usually if the patient's DNR, the risk of starting TPN may be higher than actually the benefits of starting. And all the others are actually indications for using the parental gut. And then which of the following are the most common metabolic complications associated with parental nutrition? Hyperglycemia, essential fatty acid deficiency, acidemia, or hyperammonemia. Hyperglycemia, yeah, so that's the most common because you're giving just dextrose directly, and they usually need high dextrose concentration. So that's one. There are some like liver complications, but that's usually seen more long term, but just like is usually hyperglycemia and line infections. That's usually the most common.
For the first question, if the patient was well nourished and expected to eat within 7 days, you would do nothing,
right? Yeah. So parental nutrition, you're just bypassing the GI tract and then just giving it IV, and either from TPN and PPN. Just if you don't know, the difference between TPN and PPN is TPN, you cannot give an osmolarity higher than 900 because that could cause the thing to flash. So that's why the problem with PPN is that usually we won't need 100% of their calorie and protein needs because you just can't meet it. Also, if the patient needs a fluid restriction, it's even harder because you need a higher volume in order to eat as much as you can. And it's usually short term. If a patient is expected to require PPN for more than 2 weeks, then you need to put a central line or just start PPN. Parental nutrition contains amino acids. So here at the hospital, we use 10% amino acids. Dextrose, we use 70% dextrose. Lipids, we use 20% lipid emulsions. Electrolytes, vitamins, minerals. So what's in PPN usually for vitamins and minerals needs 100% of the DRI and RDI. So if a patient needs like B12 and all like vitamin D, they're getting that. They may need additional, but they're meeting 100%. It also has free water, and PPN can be ordered either 3-in-1, which means everything's mixed in the bag, or 2-in-1, where the lipids are outside. We rarely do this, but we do it sometimes. Especially in kids where they're long-term TPN patients and they cycle like lipids 1 or 2 times a week, just because they may have higher risk of complications of like liver complications. But usually everything is going to be 3-in-1. Even if we don't give lipids, it's still going to be the same bag. It's not going to be the same bag. And access is good here. Well, I know like patients have the central lines, and the 6th line is actually a central line. For the PPN would be like the midline catheter, the peripheral intravenous catheter, and like femoral vein. Those can only be used for PPN. We cannot use those. So indication for PPN, you failed enteral trial, or just enteral nutrition is contraindicated, or if the patient is a surgical patient and the patient day 7, that's usually between 5 and 10 days post-op, we cannot start either PO or tube-feed, then we should start CPN because we don't want to start the patient. And here, also, the guidelines from Aspen were revised last year, and they recommended that if the patient's not meeting 100% of their needs from tube feeds after 2 weeks, we should use supplemental CPN. That's kind of also controversial because we know the risk of starting that, but we should consider it if a patient's been just not tolerating or losing weight, then we should start some supplemental CPN. And we've talked about the contraindications. The main complications could be mechanical, just access, infection, catheter line, sepsis, which is very commonly seen in patients on like home TPN, and metabolic, which are our main concerns. So for glucose control, if the patient's hyperglycemic, there's a policy here in the hospital. I know you know it. I'll remind you. So if someone needs insulin, they should get half of the insulin inside the bag. So the reason they do that is because a few years ago, something happened and the patient was getting a lot of insulin outside, and then the patient was not eating, and then it was not good. So half of what they require should be given inside the bag. So even, we just had a talk with Anne Levine, the diabetes nurse, even if the patient started on an insulin drip, half of that should be added inside the bag, okay? Fluid electrolytes, acid-base balance, that's where we come and we adjust usually fluids, or we adjust electrolytes, or so there's different, so we can give potassium acetate or potassium chloride, so depending on the CO2 or the chloride, we'll adjust that inside the CPN to try to help with that. There's rarely we see renal complications. Chronic TPN may cause something like bone disease. We can see some mild elevation of the transaminases. So if you see some elevation after starting TPN, that's normal. If they start trending up, then we should assess if it's the TPN or if it's something else. There's a higher risk of repeating syndrome when we're giving parenteral nutrition because it's just going directly IV. So here it's very important to monitor electrolytes and repeat them. If the electrolytes are low, then we should repeat them before starting TPN. Especially FOS, like if you see that drop, we sometimes need to hold the TPN and repeat it and then continue. And this is going to be more of an issue in patients who've been MPO for a long time, or patients who are severely malnourished, or patients with a history of alcohol abuse who just haven't been eating well. We have a problem with hypertriglyceridemia, so that may happen if the patient is getting a lot of calories or a lot of fat. So here's where we would check, and depending on the number, we may decrease the amount of lipids we're giving. And essential fatty acid deficiency is rarely seen. It used to be seen a long time ago, but it's rarely seen. It may happen in patients who we need to remove the lipids because their triglycerides are above 400, but it's rarely. So we need to monitor weight every day, intake and output, all this, BNP, electrolytes, finger sticks should be checked daily. Actually, finger sticks should be checked every 4 to 6 hours on patients who are on TPN. LFTs once a week, and then usually we would start dextrose at a lower, not a goal, same thing. If the patient's not getting dextrose, and then you just give them a lot of dextrose, and they're usually becoming hyperglycemic. So we usually start within 100 and 200, depending on different conditions. And then we would increase daily. That's why sometimes we have the TPN and then we renew them very often. It's because usually they're not a dextrose. So protein, there's usually no problem, so we just start them at full. And for lipids, the Aspen guidelines actually recommend that holding, in some patients, lipids during the first week. So the lipids that we have here in the U.S. until early this year were mainly pro-inflammatory. So if the patient's already going through a lot of inflammation, that they recommended holding them and then after starting them. But now there's been a lipid emulsion that's been approved that's less inflammatory, so we're hoping to get that here as well. But we can still start with lipids. We may not start with both, but we can still start. And then our goal, like I said, is always going to be to transition to enteral feeds or PO. So once the GI function returns, there's no risk of aspiration, the patient's mental status is okay, then we should transition to them, to PO or QP. They may need a speech and swallow evaluation. If they're young and they're healthy, we can usually just discontinue TPN as soon as they're eating and tolerating food. But we always want to do it gradually, because if we discontinue TPN, first of all, they have a risk of hypoglycemia. And second, we don't know if the patient's actually going to meet 100%, so we just need to do it gradually to make sure they're eating. If for some reason the TPN needs to be stopped abruptly for an emergency, then they should start 5 to 10% extra solution to prevent hypoglycemia, and they should check the sugar. And then in conclusion, well, nutrition intervention is essential and very important here in the acute care setting. We should always use the gut if the gut is functioning. We should reassess the nutrition intervention and tolerance daily. I know you're around, so nutrition should be part of your conversation. And consularity, which here in the ICU is usually do. So that's it.
Like, if you have patients who, like, let's say they're like well nourished and they're septic and intubated and they're going to be for days, what's your like go-to formula that you use?
So if the patient is on pressors, like MAP of like above 65, so it depends. So usually between isosource or Peptamen 1.5. That depends, like I said, on the fiber. So if the patient is not stable, then I would.
They're really high dose pressure.
Right. So then I would start triple Cs with a Peptamen 1.5, or if they're on propofol. Propofol provides 1 calorie per ml. That's why I usually ask about propofol. So patients sometimes are getting 500, 700 calories off from fat. This is just from fat. So then Vital would be the best choice, because Vital is low in calories but very high in protein. So since you're giving them calories from propofol, then you're probably meeting the calories, and now you're meeting the protein. So usually those, Replete would be another option. Replete is very similar to Vital. The only thing it's not elemental, because not everyone needs an elemental formula. It's high in protein, not as high, so it just depends on that. But usually those would be the more common ones. For someone with renal disease, not acute, because acute once you get towards something like that. But like someone on dialysis, and then I would do the Novosource renal. But usually Novosource renal would be for someone whose electrolytes are too high. If those are fine, then we can use Nutrient 2.0, which is very similar. It's just not like restricted. So like in general, for like the general population here, I would say
like that. Those are all qualified in the like energy high, whatever you said.
Yes, yes, so you can use.
That was.
I think it's always like even if you start like if there was a consult on, but it was like at 4 p.m. or something, and even if you start a formula, that's fine. Like the next day, if we need to adjust it, we can adjust it. Better to start it, and probably that shouldn't cause any big change in what the patient. Because usually you would also start QP at a lower rate and then just gradually increase. And the nurses are pretty good here in the ICU. They have all the confidence to adjust and increase and decrease. And the other thing that I want to mention before now that you mentioned, so gastric residuals. So Aspen also, they revised the guidelines and they said gastric residuals don't need to be part of the daily monitoring. The thing is that here, like nursing policy is still part of their policy. So that's why they're still checking it. But we shouldn't be holding QPs if residuals are 300. Because the amount of gastric secretions that our body, like a stomach produces, could be up to 500. So that's why the recommendation is not to hold them unless they're above 500. Of course, if the patient's having abdominal distension and vomiting, then of course, hold them. But usually if it's above to 50, we should consider using prokinetics or something to help them or ensure positioning is appropriate, but they shouldn't hold them. Maybe if they're having 400, nothing else, maybe you can lower the rate a little and see if they tolerate, but we should avoid holding the feed. Some nurses feel a little bit more confident doing it. Some may feel more confident, may just stop them if they're like 200. which is fine. They're just concerned the patient's going to aspirate or something. But in practice, it's okay. We don't need to call them unless there's another sign of intolerance. Any other questions? No? All right. Well, thanks for inviting me. All right.